I'm Dr. Carolyn Lineber, and we have a really exciting program for you tonight with Dr. Madhavi Garmella, who's a board-certified endocrinologist who's come back to Los Alamos to work with us, and it's really been fun and exciting to have her back. Tonight's talk, as you all know, is Living with Diabetes. Dr. Madhavi Garmella is our speaker tonight. She did her internship and residency at UNM Medical School. And in 2006 to 2009, she joined Medical Associates, our group here in Los Alamos, as an internal medicine doctor. And then one Christmas, she came to me and she said, "I'm leaving." And I was so sad, but she was leaving to go and do endocrinology at UNM, took a 2-year fellowship there, and came back in 2011 and has been helping and treating patients here in Los Alamos ever since. And I think you're really going to enjoy her talk tonight. Dr. Garmella?
Thank you so much for having me, and thank you all of you for coming on this cold and windy evening. Hopefully you'll be able to get something out of this seminar. So you're all here because you have diabetes, or you've been diagnosed with prediabetes, or you simply want to learn more about the condition. And I use the word condition because this is what I like to call a chronic condition rather than a disease, because this is something that you will be living with forever. So just some people are lactose intolerant, some people are gluten intolerant, and some people just do not make enough insulin. They have diabetes, and you just have to learn how to make choices based on the deficiency that you have. And so hopefully, as we go through this seminar, we'll be able to, so what I'm going to talk about is, first of all, what is diabetes? What are the types of diabetes? Why do we need to control diabetes? Diet, exercise, medications for diabetes, traveling, drinking and diabetes, as well as the marvelous resources that we have in our community to help you and cope with this condition. So diabetes, we know, is a condition where you have excess sugar in your blood. And this is both due to your body's inability to produce insulin and or use insulin efficiently. So this is where we make the differentiation between the types of diabetes as far as whether it's an insulin deficiency condition or whether it's an insulin resistance condition. So a little bit of historical background. I'm sorry that the pictures are a little small, but so in fact, it was mentioned in 1552 when in the Egyptian papyrus, the physician mentions frequent urination as a symptom, and this is what typically we find out for diagnosis. In 1500 BC, ancient Hindu writings had shown that ants were attracted to the urine of some mysterious condition. You should actually want this, yeah. So then in 250 BC, in fact, Apollonius of Memphis is credited with coining the term diabetes, and the word diabetes means going through. So anybody who has had diabetes and who does have diabetes know that they have frequent urination, so it is as if your water is just going through the body. And then the mellitus part of it was added up to the 11th century, and since the urine of people with diabetes is thought to be sweet tasting, the diagnosis was actually made by people who tasted the urine to see whether it was sweet. And so then mellitus came about because that is the Latin word for honey. And so we have the word diabetes mellitus, which is basically sweet siphoning. So we talk about the types and causes of diabetes. We have type 1. and we have type 2, and we have a type 1.5, and we have maturity onset diabetes of the young, and we have other causes, so genetic defects of insulin action, injury to the pancreas. There are some people who've had pancreatitis because of various reasons, and they have had an injury and therefore have diabetes, and so this is to do with insulin secretion because of that. Excess of other hormones. So there are some people who have excess of cortisol, for example, for some reason. They have diabetes. Drugs or chemical induced, for example, in HIV treatment, chemotherapy for various diseases, many times you end up having diabetes. And finally, viral infections. So I don't want to talk about all of these causes, but I just want to let you know that there's just not 1 and 2, but there's multiple causes for diabetes. So type 1, so I'll just talk about the 4 common things. So type 1 we all know. So we have the healthy pancreas here, where we have glucose coming in from the stomach. We have the pancreas secretes insulin, and then we have the glucose is stored and used in organs, and we have normal level of the glucose in the blood. So what happens in type 1? The pancreas does not make any insulin at all. So basically, the problem is over here. So you have less insulin, and this either could be due to a viral infection or a destruction of the cells that make insulin because you have antibodies against it. And so basically here, the deficiency is an insulin deficiency. And typically, people are younger, so it's the kids who have type 1 diabetes, and it accounts for about 5 to 10% of the cases. Type 2 is the same picture here, healthy, glucose, the insulin responds in response to the glucose, and then it gets stored and used in the organs. You have normal level of the glucose in the blood. But in type 2, the issue is a combination of the pancreas not making insulin, so it's a combination of insulin deficiency, as well as the fact that it's not able to work efficiently because of insulin resistance. So you have insulin production, but it may not be 100%. It may be 80% rather than 0, as it is in type 1. Besides, not just is there a problem with insulin secretion, but there is a problem of insulin resistance. And it is important to hold on to these concepts because when we're talking about diet, we're talking about exercise, we're talking about medications, this is what we're trying to modify. We're trying to modify the insulin deficiency, and you're trying to modify the insulin resistance in taking care of the disease, since most of us have type 2 diabetes as adults. So this is the problem here, where you have lesser insulin, and the organs are not responsive, and so the body is not able to use the insulin properly. So usually, these are the people who are usually older, they're overweight, but sometimes you may need to take insulin. So many times I have heard patients say, they used to be type 2 and I became type 1, but it's not that if you started taking insulin, you become a type 1. You still remain a type 2, but it is just that you need insulin now to manage your condition. Because type 1 is, we talked about antibodies and we talked about the fact that you don't make any insulin at all. Whereas here, you have to make up the difference of the insulin that you're not making by taking insulin. And then we talked about type 1.5, and this is a condition that we are seeing in a few patients, and what it stands for, it's called LADA also, and it's latent autoimmune diabetes of the adult. And so it's a variant of type 1, and so these are people who we've initially heard have been diagnosed, and we think that they are type 2. So they say that my doctor checked my sugar was high, and initially I started taking oral medications, but then they soon had to transition me to insulin. So these are the people where the transition is quite rapid because it is actually a variant of type 1 and it is antibody mediated. But it's older rather than in the younger population or in the pediatric population. So approximately 20% of adults who are diagnosed as type 2 actually are autoimmune based, and so they're the skinny type 2s where they don't look like they're overweight, so you wonder where the insulin resistance could be coming from, but actually it's autoimmune mediated. So we diagnose it by evaluating for this particular antibody, which is the GAD65 antibody. And when these antibodies are present, then we know that they possibly have the autoimmune-mediated type 1. So initially they don't, but around 3 to 12 years after diagnosis, they typically do need insulin. So this is the type 2s who are misdiagnosed, or rather type 1s who are misdiagnosed as type 2s. So then we also should have type 2s who are misdiagnosed as type 1s, and those are the MODIs. So that's maturity onset diabetes of the young, where they are young teenagers, and we think that they have type 1 just because they are young, but they're misdiagnosed as type 1 because we think that just because they are teenagers that they probably have type 1 diabetes and the autoimmune. But this basically is because of a genetic abnormality in signaling. There's actually no problem with insulin action, but there's a little problem in insulin secretion, and they don't need insulin. But this is just to introduce to you that there's type 1, there's type 2. There are type 2s who are misdiagnosed as type 1s, and type 1s who are misdiagnosed as type 2s. So, who are at risk? Obviously, family history of diabetes, people who have prediabetes, and I will talk to you more about what the criteria for diagnosis of prediabetes is, and we use the word prediabetes rather than borderline diabetes. Diabetes in pregnancy, so those who've had gestational diabetes do have a risk of 20 to 50% of going on to develop diabetes later on. Overweight, obviously. And certain races, Hispanic, Asian, Pacific Highlanders, unfortunately are at risk for development of diabetes. So when we're talking about diagnosis, the diagnosis is based on the fasting glucose. But now the American Diabetes Association also uses a hemoglobin A1C for diagnosis and a glucose tolerance test. So I have those three here. So normal is supposed to be a fasting sugar of less than 100. In fact, actually, some of the Tricor labs have their reference range of up to 110. And so when I say that you have prediabetes, they say, but it's normal. But the truth of the matter is, technically speaking, a fasting sugar of less than 100 is what is supposed to be normal. Prediabetes is early, so it's the gray zone, where you have sugars, fasting sugars, between 100 to 125. And diabetes is when it is greater than or equal to 126. So any fasting sugar which is greater than or equal to 126 gives you the diagnosis of diabetes. Alternatively, we can use a 2-hour post-glucose tolerance test where they make you drink the 75 grams of sickly sweet sugary stuff, and then they check your sugar 2 hours later because they want to see how your pancreas is responding to that load. So normal is supposed to be less than 140. Pre-diabetes is if it is again between 140 to 199, and diabetes is any time if your sugar 2 hours after eating is greater than 200. Now, some patients do random checks at home and they worry about having diabetes because their sugar is greater than 200. Technically speaking, if we have to use that as a criteria, we really need to do the oral glucose tolerance test. Because if you check a random sugar, it actually has to be greater than 200. And sometimes we use this hemoglobin A1C where fasting glucose could be deceptive. Normal is less than 5.7. Pre is 5.7 to 6.4, and greater is 6.5. And I only mention this because we are Los Alamos. We all like to read our labs. And when you get your labs and you want to figure out how do I interpret all of these labs, then you can refer to this chart. So hemoglobin A1C is the other common thing that we talk about. So it's basically you have a red blood cell, and the sugar molecules are attached to the red blood cell. So the life of a red blood cell is about 120 days. So when you check a hemoglobin A1C, you're able to get a snapshot in time of what your sugar control was like in 3 months. And so that's why it doesn't matter whether you're fasting or whether you're not fasting, you just go in and get a hemoglobin A1C, and it tells you what your sugars have been. Because if you just check fasting sugars, you may be misled because your fasting sugars may be doing really well, but then you look at a hemoglobin A1C and you find that your average is 150, then you know that there must be a problem, that there must be some sugars which are higher than 200 lurking in there, and that's the reason why you have a hemoglobin on an average of 150. So this is something that all of your doctors obviously talk about, and everybody keeps harping on the hemoglobin A1C. And what should the hemoglobin A1C be? The American Diabetes Association says less than 7, which translates to an average of 154, average sugar of 154. So why control? Now, I only put one slide because I know that all of you know the complications, otherwise you would not be here. So here we know that it's the leading cause of blindness and nephropathy, strokes and mortality, cardiovascular, diabetic neuropathy, gum disease, hearing loss, etc. And the problem is that if you have a debilitating event, then that's it. But the problem is if you don't have a debilitating event, but you have slow damage to your kidneys, slow memory problems, and as I heard in one lecture, they talked about slow damage of parts of your brain, and God knows if it's that part of your brain that remembers your spouse's birthday, so you don't want that kind of damage to happen. So there was a big trial which was called the Diabetes Control Complication Trial, and this was a study that was conducted in 41 patients, had type 1 diabetes, so they were treated intensively with a diabetes goal actually close to 6%. And they found that intensive blood glucose control reduces the risk of eye disease. There was a 76% reduced risk, kidney disease, 50% reduced risk, and nerve disease, 60% reduced risk. And then they followed these people. For 90% of the people were followed after the study was complete to see whether the benefits on cardiovascular complications persisted, and they found that they did. So it again, intensive blood glucose control reduced the risk of any cardiovascular disease event, and non-fatal heart attack, stroke, death from cardiac causes were all reduced. So the bottom line is tight control is beneficial because we do see that there is a reduced risk. The next question is, can it be prevented? Can it be delayed for people who have early diabetes? And the answer is yes, it can. And we have this information from this study, which is called the DPP study, which was another landmark study, which showed that patients just needed to lose 5 to 7% of their weight. That's all, 5 to 7%. So if they are overweight, so if you're 200 pounds, 10 to 14 pounds, and maintain that weight loss, and get at least 30 minutes of exercise, moderate intensity, brisk walking, yard work, playing with children, 5 days a week, which translates to about 150 minutes, to be able to actually delay the onset of diabetes. And this was actually the comparison. This was a big trial that was published in the New England Journal, where they took people who did nothing. They took people and put them on a drug, and they took people and did diet and exercise. And you can see that the diet and exercise group did much better than the metformin group. So again, we don't necessarily have to be taking medicines to prevent or delay the progression of prediabetes to diabetes. Just diet and exercise works. And in fact, the trial was discontinued 1 year early because the results were so convincing. So again, diet and exercise, everything that you hear from your physicians, everything that you hear from your diabetes educators, this is the basis for that. So the bottom line is that it's lifestyle change. It's a new way of life for you and your family. It's about learning how to break old habits. It's about not giving up. You can eat out. You can eat at parties. You can celebrate. The key point is just learning how to budget and portion. And so this is, it says, since my husband developed diabetes, I've lost 30 pounds following his diet. So it's good for your family as well. And if life, as they say, when life gives you lemons, make lemonade, only with sugar substitute, because we have diabetes. So that's the burning question, what can I eat? So carbs, the key word of the day. So carbs are needed for making glucose, which is the body's fuel. So we need it. We need carbs for energy. We cannot do without carbs. The key point is, so we want to see what are the types of carbs. We have starches or complex carbs, and these are the starchy vegetables, the grains, the beans, the peas, lentils, etc. We have sugars, which are either natural or added. So natural sugars are the fruit sugars and the milk sugars, and then we have the added. Each of these is each block of sugar is the amount of sugar that's there in each of these bottles. That's why I picked this picture. In Coca-Cola, there's 9 blocks of sugar. Drinking this is about 16, and drinking this is about 32. Just plain sugar. And then we have fiber, which is the indigestible part of plant food. So daily requirement of fiber is about 25 to 30 grams a day. And that's divided into soluble, which slows down sugar absorption, and you have insoluble, which basically adds bulk. So fiber we have in the unrefined cereals, in the fruits, soups, whole grain breads, the muffin, the wonderful muffin that we just ate, the other soups, and vegetables. So these are the types of carbs. So you've all learned about how to read a label, and I will go over it again because reinforcement is always the best way to learn. So whenever you look at a label, you start here, where you're looking at a serving size, because you need to know how many cups, how many slices, how many portions of the tortilla, etc. So you start here, you see here's the serving size, this is 1 slice. Then you check the calories per serving. You want to limit the total fat, saturated fat, etc. You're looking at the carbs. And that's the key point, I'm sure all of you know. You're not looking just at the sugars. So there's a lot of people who drink and eat and they say it didn't have any sugar, but as we just saw, sugar is just one of the 3 types of carbs. You have carbs, you have fiber, and you have sugar. So just because it didn't have sugar, it doesn't mean that it didn't have carbs. So you need to look at the total carbs. And then you look at the protein, and then you have all of these vitamins and minerals, etc. So a basic guide is that 5% or less is usually useless, and 20% or more is high. So the key point in this slide is when you're looking, you want to look at the serving size, most important, and number 2 is you want to look at the total carbs. Unfortunately, Martha's idea of diabetic exchange system was to exchange an empty plate for a full one. So we have glycemic index is another thing that we talk about. So glycemic index provides a measure of how quickly the blood sugars rise after eating a particular food, and it's compared to plain sugar or plain white bread. So that's supposed to be 100 because it's the quickest. So anything, the lower it is, the more slowly it gets absorbed. And the higher it is, the most fast burning the food is. But the caveat is that not all foods with low glycemic index necessarily are healthy. So we don't want to be fooled by just looking at the glycemic index, because both fat and fiber lower the glycemic index. So if you actually looked at the glycemic index of pizza, you'd find that the glycemic index of pizza is very low. But is it necessarily healthy? It's not, because of the fat. Because anything which slows down the gastric absorption is going to lower the glycemic index. So we have to choose carefully, and this is my question. Which one has a lower glycemic index, potato chips or baked potato? And since it's a trick question, we all know that the answer is potato chips. So that just shows that you have to choose carefully. Just because it has a lower glycemic index, it's not necessarily beneficial, which is what the American Diabetes Association says. And so they don't have a clear recommendation as far as choosing foods with glycemic index. But the only thing is that it may be beneficial because of the high fiber content. And so if you have to choose, and you have to make choices between apples and apples rather than apples and oranges, tortilla and tortilla, then you'd want to choose whole wheat versus white, brown versus white in terms of rice, whole wheat pasta versus refined pasta, whole wheat tortillas versus flour, the fruit rather than the fruit juice because of the fiber, sweet potato versus russet potato, and all of these examples that you have. So when you're making healthy choices, you want to make choices with these high grain fibers, and the reason we're doing that is because the glycemic index is low, and so you're able to, it helps you to absorb slower, helps you feeling full longer. Now this one, it says, of course, donuts are good for you. They're whole grain. Now, so then the next thing is preparing a plate. So this is a 9-inch again. All of you must have seen this in your diabetes educator regular classes. So 9-inch diameter. So when you're preparing a plate, how are you going to eat so that it's diabetes friendly? So half of your plate is your vegetables. You're imagining the plate and you're dividing it into imaginary half. Half of it is vegetables. What are the vegetables? Bunches of vegetables: spinach, carrot, lettuce, greens, cauliflower, all of those vegetables. Typically anything which grows above the ground is one byline that I use, because usually starchy vegetables are the ones which grow below the ground. And so cabbage, salads, anything, as much as you want. Quarter of the plate is your starches, and that's over here. And these are the foods which are going to raise your blood sugar. So this is going to be the whole grain breads, the rice, the pasta, the chapatis, the dals, and everything that we eat, the cooked beans, potatoes, all of that is quarter. And then the other quarter is your meat and other protein. And so in case of vegetarians, you want to eat the other part of it is your other things like lentils you're having in terms of, tofu, paneer, these kind of things which are usually high in protein. And then you add an ounce of 8-ounce glass of milk or a 6 ounce of plain yogurt, and this is your meal. And you can actually feel full in terms of eating it this way. Now, what I used was a broad plate preparation. I said whole grain breads. So the question is, how much? So how many carbs should I eat? So that's the carb budget. And there are many people who don't exactly count the carbs, but as you become more sophisticated, you count it. But it's helpful to think about foods in terms of portion sizes. Now, the reason I put up this slide is again because of Los Alamos and everybody being interested in how an equation was derived. So the basic metabolic rate is dependent on so everybody is not equal, obviously. So it depends on your gender, male, female, how much you weigh, what kind of activity you have, whether you're eating to lose weight, whether you're eating to gain weight, etc. So you calculate the basic metabolic rate, which is this daunting equation for women and for men. Or you could simply plug it into Google and it'll calculate it for you. And then you have your so you've calculated your calorie requirement. Once you've done that, your basic metabolic rate times activity factor is how much your calorie requirement is. So if you're moderately active, for example, there's a conversion factor. And again, you can just put it into an application in Google. Like I said, I just put it up here for everybody who wants to know how we came up with this equation. And so carb calories are approximately 40 to 60% of your total calories. And then the carbs are the carb calories divided by 4. So in the end of it, string theory? No, my lunch bolus. So simplified, on an average, it's about 45 to 60 grams of carbs for a moderate-sized woman with moderate activity, and about 60 to 75 per meal for a moderate-sized man. And in terms of how many foods, and that's where in your packets you have the books which tell you the serving sizes and of each of those, so that you know what foods have 50, and most of them are about 15 grams, and then you're able to eat. For example, if it's rice, then it's about a third of a cup of rice is 15 grams of carbs. So if it's 45, a cup of rice. So this is how you're estimating. Snacks, about 2 a day, and in your handout also you have other snacks which are, which give you ideas for snacks in terms of 0 to 15, 15 to 30, and greater than 30. And because I just didn't want to put all of it up here. So therefore, on an average breakdown, calories are coming about there 40 to 60% per day. Protein is about 25 to 30%. Your fat should be less than 30%. Saturated fat should be less than 7%. Fiber. So now the key, why I put the recommended daily allowance is because a lot of people follow low carb diets. Now the key point is we don't want to get too aggressive. because you do need about 130 grams per day according to the Diabetes Association, because you need that much for your brain cells to function without it drawing on your food and other storages and developing ketosis. So we really need to be maintaining a healthy balance. We don't want to be aggressive in minimizing carbs completely, but on the other hand, we don't want to be going overboard as well. So this is sort of an average breakdown, which is endorsed by all the major societies, the American Diabetes Association, the American Heart Association also. So while you're at it, would you pull out that sweet tooth? If only it were that easy. So the key point is you want to use your measuring cups at home so that you know how much a portion is, which brings us to our next point, that is dining out. So first point when you're ordering, so these are just again a few pointers. I wish I could cover the whole, so I'm trying to compress the whole of diabetes into a single hour. But tips. So for dining out, when you're ordering, you skip the freebies, the bread, the chips, the salsa, because they are the ones which are not going to be doing anything for you, but just contributing towards your carb budget. Number one. Be a diabetes sleuth is what they say when you look around and see, what do the portion sizes look like? Does it look like people are getting large portion sizes, or does it look like it's a big plate but a small portion, like an expensive restaurant is inversely proportional to the cost of the food? And so you want to look around, because that helps you to start planning so that when the waiter comes along, you know this is what you want to order and this is how you want to order it. And sauces, gravies, salad dressings, always ask for them on the side so that you have control over putting it on the foods. Eat slowly, helpful, because then you haven't gobbled up whatever little portion you had and then you're looking around for more and people offer you more food. And then ask for substitutions, and it can be done. And you ask for example, extra vegetable portions instead of fries, or that be left off. And again, I don't think there's anything to be embarrassed about it. Just like people are lactose intolerant, people are gluten-free, and if you have to, you always ask the waiter, does this have gluten, does this have, and you're vegetarian, and you say, can this be made vegetarian, etc. So I don't think that there's any harm in asking for substitutions and trying to avoid what you know is not going to work for you. And be aware of carbs in breaded foods, because particularly breaded chicken, breaded other meats, etc., they do contribute, even though they are protein, they do contribute to your carbs. And I'm going to order a broiled skinless chicken breast, but I want you to bring me lasagna and garlic bread by mistake. So examples, for example, I put up Mexican only because Mexican is where we all go out to here most commonly, and that's the most carb heavy. So choices for Mexican could be fajitas, made with lean beef, chicken, shrimp, or vegetables. These are lower fat choices. Soft tacos rather than fried taco shells, and you stuff them with all the meats, etc. Lettuce. Hold the cheese. So when you're making, for example, and you've ordered an enchilada plate, you can ask for the cheese to be held, and you can ask for the sour cream to be held, so that it's put on the side. You can ask for the beans to be portioned or replaced, and you can ask for the rice to be portioned and replaced, because they're side dishes anyway. So this way you're able to actually control, in terms of plates, what the serving size is, and when you're ordering in terms of healthy choices. It's difficult because a lot of times we go out with our colleagues, and we're going out to work, and we're going out to Decolores Cafe or somewhere, and we don't want to look different, and it's just very difficult. And that's where you can go to that restaurant. It doesn't mean that you have to avoid Mexican restaurants or Chinese restaurants. It's just that you learn how to order the correct way. Alternatively, you can also choose and ask to split the portion. You can, ahead of time, when you've seen that this is one of those restaurants where you're going to get big portions of food, you choose to split the portion ahead of time, and you say, can you box the rest? Because this is what a lot of people do, is just split it. So that way you're able to eat it for lunch the next day, and we don't feel like we're wasting, because that's another barrier that we need to cross, is we need to finish everything on our plate. But if you only have half on your plate, then that's easy to do. So that's one way to kind of have your cake, I shouldn't use, like have your enchilada and eat it too. So share dessert, so you can have dessert. It doesn't mean that you cannot have dessert. Share it though. And in cases of buffet, prepare the plate according to what we already said. So that's easy because you then have control over what you can or cannot eat in terms of a buffet. So that's easy because in the Chinese restaurant in town, because they both are buffets, you can prepare your plate according to that. But the key point is realize that the breaded pork and the breaded chicken, etc., do contain the carbs, and you have to be aware of the salt in the soy-based sauces. And other than this, typically then the other cuisine is Italian cuisine, which is often pizza. And that pizza is, again, you know that it's very slow acting. It stays in your stomach for some time because of the cheese. So choosing thin crust pizza, when you're choosing Italian food, less of the pasta, you're having more of the salad, more of the soup, and choices like that. So it's all in the portions. That's the bottom line. And so if you know what it looks like at home, and that's where it is important, you know that you'll be able to figure it out outside. And it doesn't have to be some kind of, again, string theory. It's just simply learning what the portion size looks like on your plate, so that when you go outside, you can just look at it and say, this looks like a cup of pasta, this looks like a cup of rice, this looks like a cup of anything. And so you can enjoy whatever you want. You can eat wherever you want to. You can enjoy whatever you want to. But just be conscious of the portions. Be conscious of what is in there, how much of it is the fiber, how much of it is not, and how it's going to behave in your body. This is so romantic, darling. Just you and me and your dietitian. So examples, for example, of best and worst is this is an all-American breakfast, obviously, the worst. And a new American breakfast, so hash browns and very tasty, everything looking very good, but obviously this is the worst of the breakfast. This is oatmeal, and we have a scrambled omelet with spinach. So this just to help with decision making. Mexican fiesta with big burrito and chips versus a healthy beef burrito with the beef, tomatoes, beans, and lettuce. Tuna sandwich versus turkey sandwich and fruit. Turkey sandwich is 55 grams of carbs. The tuna sandwich with the chips is 183 grams of carbs. And 1,050 calories. And this is 445 calories. The same thing, this is a southern rib plate, looks very good with corn and potatoes, and I don't know what these meats are, and macaroni. It's weird because I'm sorry, I'm vegetarian. So. But 83 grams of carbs, 2,510 calories. That's the entire calorie requirements for the whole day. So, versus, this is pork tenderloin plate, and this is apparently mock mashed potatoes. So they've used a substitution, so they used cauliflower puree so that it looks like mashed potatoes. And it tastes really good. I've tried it instead of the mashed potatoes. So it looks good. And then you have the broccoli. So here's a plate where they have portioned it exactly. You have the broccoli, you have the quarter with the mock mashed potatoes. So you really didn't have to count it in your carbs and your pork tenderloin. And this whole thing was 42 grams, 360 calories, and I think it looks quite appetizing. Eating at social gatherings. Eating at social gatherings is always, it's a little more in your control, so sometimes it helps when you bring your own dish, because then you have something to eat that you've made. And again, because I'm vegetarian, I do that all the time, since most of the time I don't know whether I'm going to have food to eat. So I bring something which I like and something that's vegetarian. So that's number one, because at least you know that your food is dependable, because you've had control in making it. Snack plate with food. So you always want to get a snack plate, and they say with food, and you hold on to the plate so that it doesn't look empty, and you stand there stylishly talking to people so that people are not going to ask you, fill it, or do you want some more, etc. And remember, the key point is the snack plate, because that is going to help you with portion control, because we talked about that the bottom line is all in the portion. The bigger the plate, the more you're going to fill it. I think diabetes is affecting my eyesight. I have trouble seeing the consequences of poor food choices. So, now exercise. Why exercise? And this is, again, I talked about the cornerstone of diabetes management. So, insulin resistance is a key point in type 2 diabetes, and this is what exercise is going to help you do. So it improves insulin resistance. So whatever drug you are taking, you will be taking less of it. If you're going to be on insulin, you will need less of it, rather than large quantities of insulin just to control the sugar. So it improves insulin resistance. We know that even 5 to 10 pounds of weight loss, just 5 to 10. We don't have to have goals of 50 or 70 or 80 pounds, 5 to 10 can improve diabetes control, because it's like a seesaw, which just has to be tipped over to the right side. So you need to incorporate it into daily activities. Keep it simple. It's not necessary that we have to have a gym membership to make it worthwhile. You can go out for a walk. You can play with your kids and grandkids, and that's sufficient exercise. And I will just talk about, again, in your handout, even since the font is going to be small here, I put in there the light intensity, the moderate intensity, and the hard intensity exercises. So make it fun. So how much exercise? Minimum of 150 minutes. So that's the prescription. So I'm trying to give you some prescriptions in terms of numbers so that you know then how much exercise, how much food, how many carbs, etc. So how much exercise? Again, just 150 minutes of aerobic exercise per week. So if you are exercising 5 days a week, 30 minutes, that's all. That's all that you need, 30 minutes per day. And so walking, gardening, yard work, and these are, again, since we're talking about the make it simple, keep it fun part, anything. So maybe you may be limited by arthritis, you may be limited by other activities, you may be limited by the cold weather. So what else? Doing yard work, swimming, cleaning house will all work to meet this goal. So anything, basically the point is you want to increase your heart rate and cause you to break into a light sweat. And children and teens should aim for at least 60 minutes though. And this is the hard part, where given the homework and everything that we have day-to-day life, to get this 60 minutes, yesterday they were talking about it on NPR, how a lot of parents want to do it, but it's just very difficult because of pressures of day-to-day activities. So it would be nice if, as in olden days, you could just come home and go to play without doing homework. So my doctor told me to find an activity I like and do it for at least 30 minutes a day. Watching TV is an activity I like. This is, I'm just going to fly through this because you have it in your handout, but it's just an examples of what are light intensity activities. You have 1 minute burns 3.5 calories, so 30 minutes burns about 105 calories when you're talking about your calorie requirements and you're talking about how much to eat and not to eat. So this is walking slowly, using golf, powered cart, slow trading in the swimming pool, light gardening, dusting, gentle stretching, etc. is light intensity. Moderate intensity is walking briskly, pulling clubs, swimming, mowing the lawn, but with motorized, not with your hand mower, tennis, bicycling, scrubbing floors, washing windows, weightlifting, etc. is moderate intensity. And high intensity is where you're race walking, jogging, or running, where 30 minutes burns more than 210 calories. So when we're talking about weight loss, weight gain, and we talked about the basic metabolic rate and how many calories to eat to lose weight, and you're trying to factor in how many calories am I really expending, how many calories am I eating, this hopefully helps to factor that in. So and that's swimming laps, mowing the lawn, singles, bicycling, moving or pushing furniture, and circuit trading. So sugars, obviously they can drop because that's the goal, but you don't want them to drop too much. And some drugs, particularly with medications like glyburide, glipizide, these are the medications where the sugars are actually going to drop, because we will talk about how these medicines work. They work by increasing your insulin production. So you have the insulin, and it's a switch that's turned on. It does not know that that you're exercising. It's just turned on. So this is where you have to be careful, and people who take insulin need to be able to adjust their insulin based on that. So if you're planning to walk after a meal, you do need to adjust your insulin to account for that. Always keep glucose tablets and a granola bar with you. You always want to stay hydrated, and have a medical alert bracelet. So this could be in any form. I always talk about this because we need to know if somebody finds it, and people say they don't look, but I guess that's a chance that you're taking. So this could be the form of a necklace, this could be a bracelet, and I have had a couple of patients who've had diabetes tattooed. So testing, key point, as you all know. So checking sugars, the key to successful management, because you need to know how you're responding to a particular treatment. So on insulin, typically you want to, when you're fasting, before meals, after meals, and I'm not going into the details of boluses, et cetera, but the reason you want to check is because you want to try to adjust your insulin based on what your sugar is. Because your insulin, we're trying to think like the body does. Basically, we've taken over, our mind has taken over the function of the pancreas. So your pancreas can sense automatically how much sugar is coming in, what's the sugar, et cetera, but now when it's not working as well, you need to compensate and you need to do the math for the pancreas. And that's the reason why you want to check it so that you know what the sugar is, and you have to, the whole game is trying to mimic what our body would have done. And that's the key to successful management. And that's the hardest part. And you realize what a wonderful organ our pancreas is, or what a wonderful body we have, only when you try to imitate it. But insulin, you need it for your meals to account for the carbs that you are eating. In type 2 diabetes, there's no clear guidelines you want to discuss with your physician as far as how many times you check, because it depends on whether you're changing drugs or you're not changing drugs, in terms of your fasting sugars, whether they are controlled, whether the problem lies with your post-meal sugars, et cetera. So your doctor would be able to give you guidelines as far as when you should be checking, because in some people, fastings are all wonderful, all less than 120. But hemoglobin A1C is still high. So that's when your doctor may say, get a couple of sugars before you eat, get a couple of sugars after you eat, so that you know what's happening. So that is a discussion that you have with your doctor about 2 days a week, 2 to 3 days. Anytime you feel your sugar is high or low, you should check. And the goal fasting I put down. So what are we aiming for? The goal fasting, even though normal is less than 100, the goal for diabetes is not 100, it's 70 to 130. And this is again, the American Diabetes Association goal. So we are aiming for fasting sugars less than 130, and we're aiming for 2-hour post-meal sugars of less than 180. And the 2-hour post is from the time you put the first bite, not when you finished eating. Because if you ate in the European method, you would take about 2 hours to finish eating, and then you'd be checking it 4 hours after. So you want to check it just after you put the first bite. And that should be less than 180. Testing your blood sugar. So the key is rotate sites, because that helps you so that you're not running away like that poor gentleman in that other cartoon. So he says, I don't think that's what they mean by rotating injection sites. I think you can't see, but it basically says Monday, bedroom, Tuesday, den, Wednesday, foyer, and Thursday, bathroom, Friday, hallway, Saturday, yard, and Sunday on the porch. That's not. So alternate site testing, people ask about alternate site testing because the fingers get so painful since you're checking, and particularly if you're on insulin, you're checking about 6 times a day, then it gets really sore. So other than rotating sites, one of the other options is alternate site testing, and there are some meters which allow for alternate site testing. And these blue areas are sites that you could check. So other than the fingers, you could check on the palms, you could check on your arms, the thighs, and the calves. But it is not preferred if you've just taken insulin or during or after exercise, only because of the fact that the blood flow in the circulation changes. If you feel like your sugar is low, you don't want to check at alternate sites. When you're preparing to drive, again, it's important to know if your sugar is low when you're preparing to drive. And stress, or when you suspect you're ill. But at other times, if you want to check routinely and you don't want to use your fingers and you want to figure out where, then these would be alternate site testing. Those sticky notes are, as you can see, your wife left a few messages reminding you to check your blood sugar. So, now, just a little bit about drugs, because a lot of you are on drugs and you may want to know, what are these drugs doing for me? So essentially, it's this seesaw that we talked about. So it's a balance between insulin on one side, and on the other side, we have glucagon, growth hormone, cortisol, stress hormones, all of these hormones raising your sugar. So when we want to restore this seesaw back to balance, we can either work here, we can increase your insulin, or we can work here, which is where we decrease the elevated glucose that is caused by all of these hormones. Now, we can't, stress hormones, of course, we can control, but everything else, we want to try to decrease the effect of these hormones on the liver, which puts out glucose. So basic management, therefore, you have the metformin and glucophage, which almost everybody takes. The role of that is that it improves insulin sensitivity. So it works on the other part of the slide. So it's not doing anything to your insulin, but it is basically helping you to use your insulin more efficiently and cut down on the liver glucose production. So that's metformin. Glipizide, glimepiride, glyburide, a lot of you take, and what they do is increase insulin secretion. And again, the reason I put this slide up is because a lot of patients are worried. They say, I'm taking so many medicines. Do they all work well together? And the answer is yes, because each of them are targeting a specific aspect of your diabetes. So the metformin, helping to improve your insulin sensitivity, is not doing anything to the insulin. The glipizide, that's increasing the insulin secretion. Glinides are commonly known as Prandin and Starlix people take. So those increase insulin secretion after meals. So they're a little more specific. It's like turning the lights on when it's dark, as opposed to turning the lights on all the time, which is what the glipizide and glimepiride do. It doesn't know whether you've eaten your meal or not eaten your meal, whereas the glinides help with post-meal sugars. And then lastly, there's this whole new class of what we call the DPP-4 inhibitors, and they are medicines that you've heard of, Januvia and Onglyza, and all the gliptins is what they're called. And so they decrease the glucagon, which is what which I showed you in that other, the other side, so glucagon on that side. So they decrease glucagon and they increase your insulin after meals. So as you can see, somebody who's taking all 4 of these medicines is targeting the insulin pathway and the diabetes pathway in different ways. And then, of course, we have the injectable medicines, which are the Byetta, Victoza, and Bydureon. They are the injectable ones. They also decrease glucagon. They increase insulin after meals, and they keep you feeling full. And so the key point is, therefore, you eat less, and it helps you with your sugar control. And then we have insulin, long-acting, mealtime insulin. And then we have insulin pump, which is basically a device, which I just put a picture, it looks like that. Small, some of you may already have it. Small pager-like device, which is connected, there's a tubing, which is connected to your body. So this is where the catheter is, which delivers insulin. So it's delivering insulin at all times. So we are trying, basically, this is the closest that we have to what we call an artificial pancreas without having the pancreas outside. You're trying to mimic what your own body would do with diabetes. So it has a little reservoir, and so the insulin is stored in there, and then just pumps insulin all along. And so the key point is that it prevents you from taking multiple shots because you have that one catheter that's in there. Some people wear their hearts on their sleeves, and I put my pancreas on my hip. And that's the insulin pump. So, travel. Again, see a doctor before you go because it helps to know whether your diabetes is in good control before a long trip, particularly because you don't want to be having sugar emergencies in the plane, low sugars and high sugars. And I know people who have had, unfortunately, sugar emergencies on planes. Medical IDs so that you have all of your information so that if you need to, then people can easily find out what medicine you're taking, what condition you have. Pack at least twice as much medication and blood testing supplies as you think you need, again, because you don't want to run out of these medications in Mexico. And eating in the air, that's another, you can ask for a special meal. So they do have diabetes special meals, and you call ahead, which is, again, like I said, since you're vegetarian, my parents are even stricter vegetarians, we always call ahead and ask for specific Asian vegetarian meal, and so it can be done, and you ask for diabetes meals. Take your own snack. It's always helpful because you never know when food is going to arrive. And of course, in America, we don't have to worry about that because food is never going to arrive. So you take your own snack to help you, other than pretzels and peanuts. Wait till you see the food cart in the aisle before. So we're talking about long trips I'm talking about because as I said, in domestic flights, it's not an issue. You always want to take your own snack. Whereas in international flights, you want to wait till you see like Dr. Kuzminski going to Moscow, and you want to wait till you see the food cart in the aisle before injecting your insulin. Because the food has to be there. You don't want to inject your insulin, and then the food is delayed because there was turbulence in the aircraft and they had to take all the food carts away. And that happens as well. So the other thing is because it's pressurized, you try not to inject air into the bottle. Because you'll meet with resistance. But this, it's just for people who are on insulin. I'm sure you already know these tricks. But the key point here, medical IDs, always take your own snacks and always pack more than what you need. And so again, I should get points or diabetes miles towards a free vacation with all the effort I put into controlling my diabetes. So, if only. So again, I'm not going to go, this diabetes bag is in and I put this up just so that you have a sort of handy thing to refer to when you're traveling. So it talks about insulin and syringes, blood and urine testing supplies, all oral medications, other medications, glucagon for people who use the emergency pen for hypoglycemia, antibiotics, anti-nausea, your ID, diabetes identity card, well-wrapped, airtight snack pack of crackers or cheese. So these are examples that you can take. Peanut butter, fruit, etc. Some form of sugar to treat low blood glucose. So the end of all of this packing that you have done, you look like the discreet diabetes traveler with everything. So, you have everything. You have the white-brimmed hat and blood glucose logbook, walking shoes, breathable cotton socks, etc., etc. But the key point again is your medicines and more supplies than you think you will need, because that's the best way to be prepared. Drinking. So these are equivalents. So a 12-ounce glass of beer is equal to 1.5 ounces of a hot drink is equal to 5 ounces of red wine. So when you're drinking, again, you know how to portion your drinks. And women should drink 1 or fewer, and men should drink 2 or fewer alcoholic beverages a day. That's the limitation. You don't want to be drinking 1, preferably less. That's the key point, is or fewer. So drink alcohol only with food, because you want to slow the alcohol absorption in your blood. Drink slowly. So slowly is again another buzzword for diabetes. Eat slowly, drink slowly, order slowly, everything, because you want to take your time, because that way you're sending the signals to the brain that I'm satisfied, I don't need to be wolfing down stuff. So drink slowly. Avoid sugary mixed drinks, of course, we know, sweet wines or cordials. Mix liquor with water or diet soft drinks. So when you're drinking hard liquor. To dilute it, check your sugar always before and after drinking, because the key point is that alcohol can cause hypoglycemia. And it can affect your liver, and basically it prevents your liver compensating mechanisms to produce glucose. And so you can become seriously hypoglycemic with alcohol, and unfortunately it's very difficult to distinguish both of them. So if somebody has hypoglycemia, they look drunk, and somebody who's drunk look hypoglycemic. So the key point is you do have to be aware that it can cause hypoglycemia when we're out there drinking. So in a bar, drink slowly, water down your drink, and try to limit yourself to one of those servings, which is a beer or a hard drink or a soft drink. And that's not what the doctor meant when he said to use alcohol after each injection, Howard. And you can still enjoy a cocktail before dinner. Have you ever tried a fish oil martini? I think that would be disgusting. So kids. Now kids, unfortunately, it's both type 1 and type 2 are on the rise in kids. We don't know why type 1, but type 2 obviously because we're just becoming overweight. We're not having time for that 60 minutes of recommended exercise. We don't have time for food preparation, etc. So the key point is we have to be able to emphasize healthy habits and healthy weight. It's easier said than done, I know, but the key point is you just have to emphasize, and you emphasize by making an example of yourself. Exercise. And type 1, now patients who have type 1, they need to have a school plan. They need to monitor their sugars, particularly during illnesses. It should not stop them from leading normal life. They can have parties, they can go for sleepovers, they can do everything that they can, and there's devices, they have insulin pumps, and I think kids cope much better than us adults because it becomes a way of life, carb counting, carb bolusing, etc. And diabetes camp is another interesting, UNM has a diabetes camp where they go for a week to the Manzano Mountains just to help so that they are able to interact with other kids who have diabetes and just have a fun time. So that is something if kids in the audience could look into for going into diabetes camp. Last few slides. Preventive care, make sure you get your yearly flu vaccine. Pneumonia vaccine, doesn't matter what age. Tetanus and pertussis, and hepatitis B for all patients less than 60. You want to check your feet annually. So this is again, since we're talking about complications, we know retinopathy, neuropathy, and nephropathy, etc., all the pathies. So you check feet annually for neuropathy. Eye examination yearly. Urine examination for microalbumin, which is a type of protein, because you want to catch the disease before you're leaking large quantities of protein in your urine. So micro is the small stage. So the analogy that I use for most of my patients is a tea strainer, for example, and normally you should just have tea coming down. But if there is a problem with the tea strainer, you want to catch it when you're beginning to see tea dust, not when you're actually able to see tea leaves, unless you're reading tea leaves. So you want to catch it early, and that's the reason why microalbumin helps you to detect a kidney problem early. So you want to make sure that this is being done every year. Gum and teeth health, a lot of people have gum disease because of it, and baby aspirin a day is recommended, in fact, by American Diabetes Association. So numbers, ABCs, the A is the A1C, less than 7, less than 6.5, according to the American Association of Clinical Endocrinologists, that's the goal. Your doctor is saying, what's my hemoglobin A1C? You want it to be that. B is blood pressure. And in fact, American Diabetes Association just released a position statement last month, which revised their goals, and they said less than 140/80. And C is cholesterol, which is the LDL, that's the bad cholesterol, and that should be low. So L is for low, and so you want it to be low. And H is for high, and you want that to be high and healthy. So when you're looking at your lab and you say this 4 types of cholesterol, and you don't want to make the mistake of looking at the total cholesterol, you want to look at the HDL and LDL. Because sometimes the total cholesterol could be high because you have a lot of good cholesterol. It could be high because of the triglycerides. So LDL goal, less than 100, and in selected cases, less than 70. So key point, therefore, want to eat well, portion control, budget the carbs, choose the right carbs. Exercise, 150, choosing the right carbs is using the glycemic index that we talked about, choosing high fiber foods, exercise, taking medications, regular testing, and regular checkups. So it's the diet, exercise, and testing mantra. These famous people, you can be anything that you want, but I found it quite interesting, that Halle Berry has diabetes, and Billie Jean King, the tennis legend, had diabetes, as did Arthur Ashe. So a lot of people have had diabetes, and that has not stopped them even from swimming the English Channel. Now, and the last part is, can it be reversed? Now, diet and exercise can prevent progression of prediabetes to diabetes. I showed you the trial, and we saw that 5 to 10%, and same thing with intensive diet, but it did prevent, even better than the drug. It can definitely delay complications. We reviewed that trial where it showed big reductions in complications, and can be placed into remission, is the word that I use, by procedures such as gastric bypass surgery, because you have really not cured the problem of insulin deficiency. So whatever was the underlying problem in terms of failure of the cells have not been fixed. But you have been able to fix a big component of the insulin resistance part of it with gastric bypass surgery. And so certainly can be placed into remission. It depends on the type of diabetes. So you're not alone. Your primary care provider, your endocrinologist, your diabetes educator, support group, online resources. And thank you all for coming tonight. And I put in the resources.
Thank you very much. That was wonderful. I have a few questions to start with, and maybe people will have more. What about Actos?
Actos?
Actos.
Okay, so Actos is one of, so I didn't put that up in my group, but it is also an insulin sensitizer. Actos and Avandia, they both belong to that group. Now, Actos gained a bad reputation a couple of years ago because there was a large Swedish study, and a study that was published out of Kaiser Permanente in California, talking about increased risk of bladder cancer. So we all stopped using Actos, but it's a good insulin sensitizer. And I think the key point is that some of the physicians still use it if they're not able to use metformin and the patient doesn't want to use insulin, because the bottom line is that diabetes itself is a pro-cancerogenic condition. So Actos can be used in select populations, and the way it works is that it works as an insulin sensitizer, just like metformin.
How about the consequences of eating corn syrup, high fructose in patients with diabetes?
So it has to be counted. So it belongs to that sugar category. So you do want to count it in your carbs. I don't know that there is any evidence which shows that it's damaging to the pancreas. The fact is that you don't. What I say is we use high fructose corn syrup is obviously sugar, but in all of these we do have to understand that our gut has sugar receptors. And that we know because they have done an experiment where they've injected 75 grams of glucose IV, and they've had the patients take 75 grams of glucose by mouth, and you find that your body responds differently. And this is the reason why gastric bypass works differently than gastric stapling. So in both, the size of the stomach is reduced, but in gastric bypass, you've bypassed all the gut hormones. And so the high fructose corn syrup and all of those do affect, because they are affecting the gut hormones and they are causing insulin secretion, and they all therefore will contribute to worsening sugars, as do the sugar. So artificial sweeteners, a little bit better, but I wouldn't say that they are the best.
How about, is turkey better than tuna, and why?
Yeah, I don't know why it is better, but turkey is better than tuna in terms of leanness of the meat.
And lower blood sugar in the elderly, is that more dangerous?
Yes, absolutely. So we do want to be aware of those that's why we say 7% and 6.5 in certain cases, because we do want to reach a fine balance between perfect and too perfect, I would say. And this is what I tell my patients also. I'd rather tolerate a sugar of 150 than a sugar of 50, because 150 you can live with, and it's going to be time which is going to cause complications. But 50, you just need to have 150 at a wrong time with fatal consequences. So yes, definitely low sugar to be avoided.
Should I have a GAD 65 test, and what will it tell me?
So if your doctor feels, so if they're trying to figure out, and this is more in the younger, where I talked about the 1.5 diabetes. So sometimes when people are insulin dependent and they want to know whether they're insulin dependent because they have type 2 with insulin resistance and so they just need more insulin, or whether it's because they're not able to secrete, then they can talk with their doctors. And that what it's going to tell you is whether you have antibodies against your pancreas, because then you have type 1 and you probably will need insulin, and it won't be controlled well by oral medications alone.
So metformin is so commonly used. Are there any downsides to it?
So metformin, there are some restrictions. You don't want to be using it in patients with kidney disease. So it is excreted out through the kidneys, so it can cause a condition which is called lactic acidosis. So we do want to be careful in certain populations, particularly the elderly populations where the creatinine needs to be looked at. So other than the usual side effects, which if people are able to get past diarrhea and feeling nauseated, etc., it's a good drug unless there is a specific contraindication like problems with kidneys and problems with lungs. So sometimes we don't, and also contraindicated in severe liver disease. So these are the populations where we would not want to use metformin.
By the way, these are great questions from the audience. Wow.
Yeah.
So another one, how long before food should be, how long after eating should I take my oral medications?
So you can take it, I don't think there is any time significance as far as, so metformin, you can take it with food, and the reason is that it helps to limit the side effect of diarrhea if taken with food. Glyburide and glipizide and Prandin, preferably taken before food, just because you have, with the glyburide and glipizide, you have excess insulin secretion, so you want to have food in your body. And with Prandin, because it is working to raise insulin secretion, you also want to take it before food. So.
And then, do you know, or have there been any research studies in New Mexico on individuals who are vegetarians or vegans, and what is their incidence of diabetes?
No, I'm not aware of any study. And in terms of incidence, I think it's the same with vegetarians, and because it all depends on your being overweight and in terms of and how much, because you could be vegetarian, but you could eat a lot of carbs just by being vegetarian as well. So it's not necessarily healthy to be vegetarian.
Are there any side effects of the oral medicines, and what should we watch out for?
So metformin, the commonest side effect is diarrhea. The commonest side effect with the glyburide and all of the G medications, glyburide, glipizide, glimepiride, is low sugar. So oftentimes that's why you need to make sure food timing is important. You don't want to take it, then go out in the yard and forget breakfast, because that can drop your sugar down. And the same thing with Prandin, and that's where the timing comes, because you want to make sure that you are taking it with food, or at least that you eat after taking the medication, because the sugar can drop. And Actos, we talked about the concern for bladder cancer. Avandia, nobody's using anymore because of the heart failure risk for the orals. Yeah. And then the gliptins, sitagliptin and all of those medicines, there is concern about pancreatitis. So you do want to we are careful when we are prescribing it to people who've had pancreatitis or pancreatic cancer.
Could you comment on people who have poor oral hygiene, the inflammatory response to gum disease, and its stimulating or causing effects of diabetes or heart disease? That's a big question.
I know.
But very important.
Yeah, so We do, so number one, we do know that there are several bacteria which live in the mouth, and they all can get into the bloodstream and cause problems. And if you have a damaged valve, you can have problems with the valve. If you don't have a damaged valve, you can have other causes of sepsis, etc. because of that. So the key point is you want to eliminate bacteria, number one, because of the systemic implications. Number two is, what was I going to say? No, that's the main thing, is systemic implications of bacteria in the mouth. And the second thing is that also it's difficult, it's harder to heal when your sugars are out of control. So you have more problems with periodontitis and other lumps and bumps on the gum when your sugar is poorly controlled. So both A, for the cause, it causes worsening, and B is if you have established periodontitis, it is bad for the general circulation.
And last question, why is hemoglobin A1C not a complete screening test for diabetes?
It should be. According to the American Diabetes Association, it should be a screening test, because if you just check fasting sugars alone, you could be fooled. So the American Diabetes Association uses all three. It uses fasting, it uses 2-hour postprandial or a random, which is greater than 200, and in fact, they have included hemoglobin A1C as well.
Well, this has been a wonderful evening, and I know Dr. Garmella would be happy to take some of your other questions if you want to come up and see her after we finish. And remember to fill out those surveys, and again, we want to thank Dr. Garmella for coming and for you all for coming tonight.
Thank you. Thanks for having me.